All right, welcome back. Chapter 31, Head Trauma. If you're going to follow along in your textbook, you're going to be on page 928, 928. Follow along in your textbook. It's going to be a fairly short chapter. We're going to be talking about, review the anatomy of the skull and brain, and then we're going to talk about head injury. Our case study introduction: EMTs have arrived on the scene of a motorcycle collision involving a single patient who was ejected from his bike when he struck the side of a car. The patient, a male in his 30s, was not wearing a helmet. Matt and Luis's initial impression is that of a patient who is not responsive and whose airway is compromised by facial bleeding. What are the first steps the EMTs must take? What findings would lead the EMTs to suspect suspect a traumatic brain injury or TBI? What types of head injuries may have occurred from this mechanism of injury? Go back and let you look at the case study again. I will tell you that the case study in the textbook is a little different than the one in the slide presentation. Okay, here's the questions. I encourage you to write them down so that you may attempt to answer them throughout the chapter. Okay. Head injuries can be life-threatening and can lead to permanent disability. The patient's mental status can make assessment difficult. Prompt recognition and proper treatment are critical to patient outcomes. So, injuries to the head, if you're looking in your textbook under the introduction, pose some of the most serious situations you will face as an EMT. The patient is often confused and unresponsive, making assessment of his condition difficult. Drug and alcohol use also cloud the assessment and make head injury diagnosis difficult. Head injuries to a patient can occur days or weeks before the onset of any signs or symptoms. Treated a 16-year-old male. Went to the restroom, went to stand up, and became weak on the left side. Had some left side paralysis and weakness. Didn't know what was going on. Turns out we assessed him for a stroke, and turns out that he had a massive brain bleed on the right side that had been going on for days, and they didn't know it. So, you know, these conditions could occur, and then days or weeks later cause the patient to actually present with a problem. All right, the anatomy of the skull and brain. The skull, the cranial skull surrounds the brain. The face is made up of 14 bones. The basilar skull is the weakest portion. Some of the basilar skull bones are thin and perforated extensively by the spinal cord nerves, and blood vessels. If you flip over to the next page of your textbook, it gives you a diagram and picture of the bones in the skull. And this is what I'm talking about right here. You will need to know these bones. They will make references in the text and in the test about the bones, and especially the orbital section here, the eyes. You need to know that this is the maxilla, the upper jaw, some people may call it, and then the mandible, which is your jawbone. You need to know the difference between those two. All right. So take the time, and look at those things. Temporal, you need to know where the temporal bones are. Parietal bones, frontal. You obviously know where the nasal bone is, and then the occipital bone in the back. The brain is cushioned by cerebrospinal fluid, or CSF. CSF leaking from the nose or ears is an indication of a basilar skull fracture. So if we go back and we see the nose and the ears over here, if there's a fracture in here or up here somewhere that that CSF can leak through, then you'll be able to see it coming from the nose or the ears. That's why when we do our trauma assessment, we always check for fluid coming out of the ears, nose, or mouth, and eyes. The meninges are 3 layers surrounding the brain. The outermost is the dura mater. The next layer is the arachnoid. Beneath that is the contact with the brain, is the pia mater. We talked about this before. This is just a review. This should be, you should either remember this or it should be coming back to you, because we talked about this in anatomy. The meninges, bleeding that occurs between the dura mater and the skull, is called epidural. Subdural bleeding occurs beneath the dura and is usually venous. Bleeding that occurs between the arachnoid membrane and the surface of the brain is called subarachnoid hemorrhage. You will need to know the difference of these 3 bleeds. And here's the meninges of the brain. You have the cranium, which is the bone, the dura mater, the arachnoid mater, pia mater. Then you have the cerebral cortex, which is the brain itself. Then the cerebellum, down at the bottom, the medulla oblongata, and then the spinal cord. You need to know where these things are. Parts of the brain, the cerebrum has 2 hemispheres. Each hemisphere has 4 lobes that's responsible for conscious and sensory functions, emotion, and personality. The cerebellum coordinates movement and reflexes that maintain posture and equilibrium. So if we go back and look, the cerebrum, which you're going to be looking at, is the cerebral cortex here. Has 4 lobes, and then there's the cerebellum. The brainstem, made up of the pons, midbrain, and medulla oblongata, controls automatic functions including cardiac, respiratory, and vasomotor function. The medulla connects the brain to the spinal cord. Go back and look at it again. Your medulla oblongata, a very protected part of the brain. Obviously, it controls a lot of things connected to the spinal cord. One thing I want you to see here is that it controls automatic functions like your heart, your respiratory, your lungs, breathing, vasomotor function, the smooth muscles that surround all of your blood vessels that make them constrict and dilate. So be thinking about that. All right, scalp injuries. Soft tissue injuries. Blood vessels do not constrict well. Bleeding can be profuse. Bleeding beneath the scalp can make assessment of the skull difficult. Skull injuries. Deformity requires extreme trauma. Most skull fractures are linear. Depressed skull fracture occurs when the bone ends are pushed in toward the brain. Skull fractures can be open or closed. An open skull fracture is when you can actually see inside the cranium, down to the dura mater, probably the cerebral cortex. And then closed is obviously where you're looking at the bone, but the scalp may be cut, but you can just see the bone. It's not broken. A basilar skull fracture involves the floor of the cranium. Underlying brain damage may occur. Head injuries are funny because there's so much that you can't see, and just a minor injury to the head could cause some a severe condition. So just be careful when you're assessing your patient if they've been involved in trauma and they're having altered mental status, maybe fluid leaking from ears or nose. That you do a full assessment of the head. Swelling and bleeding within the skull can increase the pressure within the skull, which decreases brain tissue perfusion. Brain injury caused by trauma is often referred to as a traumatic brain injury. You will see this abbreviation plenty of times in the field, TBI, and that's exactly what you're talking about, traumatic brain injury. And any patient that's ever had a TBI will be calling it a TBI. The pathophysiology of a traumatic brain injury. Traumatic brain injuries can occur from penetrating trauma, blunt trauma, or secondary injury. Brain injuries can be open or closed. Here's some examples. The top, the baseball, that's blunt force trauma. You may see some structural damage, skull injury, hematoma that's pressing on the brain. So any kind of bleeding in that dura mater, under that dura mater, could cause pressure on the brain, causing some causing secondary factors to occur. If you look on the left, you see primary injuries, laceration or shearing injury, contusion, swelling, hemorrhage. Lacerations occur with or without skull injury. Bleeding and swelling occur around the areas of contusion. The brain damage, you see, it says hematomas and brain swelling lead to increased pressure inside the skull and compression of brain tissue. Secondary factors are loss of consciousness, respiratory and circulatory changes may result from primary brain injury and increased pressure on the brain. Some signs and symptoms that you can look for. Decreasing mental status from confusion to coma, deformity of the skull, drainage or spinal fluid or blood from nose and ears, discoloration around the eyes, which will be late, unequal pupils or pupils that do not respond to light, respiratory changes, systolic blood pressure may increase, heart rate may decrease, abnormal posturing, and sensory or motor deficits. A primary brain injury is the result of trauma to the brain that occurs at the time of insult from direct impact, acceleration or deceleration, or a penetrating wound. This is what caused the very initial brain injury, primary brain injury. Secondary brain injury from a TBI will be worsened by hypoxemia, hypercarbia, hypoglycemia, hyperglycemia, hyperthermia, and hypotension of a systolic of less than 90 millimeters of mercury. To minimize secondary injury, maintain a patient's airway, adequate ventilation, SpO2 greater than or equal to 94%, systolic blood pressure greater than 90 millimeters of mercury, normal body temperature, and a normal blood glucose level. Stop seizures as quickly as possible and consider contacting an ALS unit. There's nothing we can do to stop seizure as EMT basics. We would have to just make the patient safe, move things around so they don't hit their head or injure themselves. We would consider an ALS unit because they can give certain medications to hopefully stop the seizure. Brain herniation is an increased intracranial pressure from bleeding or swelling which forces the brain out of its normal position. Compression of the brain causes dysfunction. Herniation obliterates vital brainstem functions. If you look at a picture, a side profile picture of a cutaway skull down by the right above the cerebrum, there's a break in under the cerebrum by the medulla oblongata. There's a break in the bone structure at the very base of the skull. It's normal. People have a certain condition where that part of that brain matter will seep out. I actually have that as well, but I wouldn't consider it a brain herniation as of yet. But it could, if I were to suffer a severe TBI, possible. So something to think about. Brain herniation signs and symptoms: dilated or sluggish pupils on one side, weakness or paralysis, severe alteration in consciousness, abnormal posturing, abnormal breathing pattern, Cushing's reflex. And so you know what Cushing's reflex is. If I can spell right. It's also referred to as a vasopressor response, the Cushing effect, the Cushing reaction, etc., is a physiological nervous system response to increased cranial pressure that results in Cushing's triad of increased blood pressure, irregular breathing, and bradycardia. Closed and open head injuries. An open wound to the head does not signify a more severe brain injury. The lack of a wound to the head does not indicate a lesser brain injury. Closed head injury: the scalp can be lacerated, but the skull remains intact. In an open head injury, a break in the skull and a break in the scalp. All right. Brain injury from shearing, tearing, and stretching nerve fibers is known as diffuse axonal injury, or DAI. DAI interferes with the transmission of nerve impulses. DAI is related to severe acceleration and deceleration forces. May be mild, like a concussion, or moderate or severe. There will be a closed head injury. So laceration to the back of the head, scalp, but no break in the bone. An open head injury, we can actually see the cerebral cortex here. Like it said earlier, that doesn't mean it's a severe laceration and there's going to be some repair to the bone, but that doesn't mean he has a severe brain injury. And just because that doesn't break the skull doesn't mean that there's not a severe brain injury. Concussion is usually referred to as a mild DAI. The presentation ranges from momentary confusion to brief complete loss of responsiveness. Usually results in headache. Effects occur immediately and gradually improve. If you ever work as an EMT and you work some extra duty at a football game or such, you'll probably see some of this. A contusion is bruising and swelling of the brain. It can accompany a concussion, may or may not cause increased intracranial pressure, caused by counter-coup, or acceleration and deceleration mechanisms. All right. I'm looking up coup and counter-coup. Coup injury occurs under the site of impact with an object, and contra-coup injury occurs on the side opposite the area it was hit. So if there's blunt force trauma to the right side, the actual brain is injured on the left side. That's contra-coup. All right. Subdural hematoma, a collection of blood between the dura mater and the arachnoid, results from damage to bridging veins in the skull. The hematoma can lead to increased intracranial pressure, which will give off some of those signs and symptoms that we talked about earlier. And here's a good little picture of it. If you look on the right, you see the dura mater, you have the hematoma, hemorrhaging inside that dura mater, putting pressure on that cerebral cortex. Subdural hematoma, acute signs and symptoms begin immediately. Occult means signs and symptoms are delayed for days to weeks. We go back, we talk about the kid who had that brain bleed. No telling how long that was going on. There was no way to tell. But it was massive enough to know that it had been going on for some time. The elderly, those with delayed blood clotting, and alcoholics are at increased risk. So what they're saying is people who are on blood thinners, elderly, their blood thins out. Alcoholics, their blood is a lot thinner. They're increased risk with these head injuries. Epidural hematoma, more rare but extremely emergent, often associated with fracture of the temporal skull. Bleeding is rapid and severe, causing a rapid increase in intracranial pressure. Late signs can include fixed and dilated pupils, absent reflexes, and decreasing vital signs. And there we go. So now we see the dura mater is still in contact with the cerebral cortex, but the bleeding is occurring outside the dura mater, between the dura mater and the cranium itself. And it's giving you an example over here, middle meningeal artery, which if it's fractured and breaks, this is outside the skull, between the scalp and the skull, and break could cause that blood to go inside that fracture line and cause this bleeding right here. All right. Laceration may occur with closed or open injuries, results in bleeding and nervous system disruption. With isolated head trauma, Cushing's reflex can cause the patient's systolic blood pressure to increase and the heart rate to decrease. All right, back to our case study. Matt immediately performs an inline spinal stabilization and uses a jaw thrust maneuver to open the airway as Lewis prepares to suction the airway. The patient has been bleeding from his nose and a hematoma over the frontal area of his head and many abrasions to his face. His breathing is deep and rapid. His radial pulse is strong and about 60 per minute. The patient responds to pain with non-purposeful movement. What immediate indications are there of a traumatic brain injury? What additional information do the EMTs need to obtain through their assessment? What are the treatment goals for this patient? And go back to the case study. Let you look at that. And we'll go back to the questions. I encourage you to write them down so that you can go back and answer them as we proceed in the chapter. All right. Click on the sign that is most consistent with a concussion. All right, give you a few seconds to look at that. A, B, C, or D. I encourage you to pause for a second because I'm going to move a little bit quicker than some of you may choose an answer. And if you chose D, you would be correct. A concussion is characterized by an initial period of unresponsiveness or confusion, followed by improving mental status. All right. Assessment-based approach for head injuries. When we do our scene size up, unresponsiveness or altered mental status suggests a head injury. Signs of head injury may be apparent. They may not be apparent. Never assume that mental status changes in a trauma patient are due to drug or alcohol intoxication. That may be the case, but it also may be because of a head injury. A fractured windshield indicates a probable head injury. Now that's looking from the inside of the car out, obviously. And if you see where that windshield is fractured and pushing outward, then you can pretty much guarantee that somebody in some part of someone's body hit that windshield, most likely the head. A good indication would be blood and hair hanging from the fractured windshield. It sounds a little surreal, but it has crazier things have happened. All right, mechanisms of injury: motor vehicle crashes, assaults and violence, falls, sports and recreation. All right, Assessment-based approach for head injury. During your primary assessment, manual inline stabilization of the spine. We want to make sure we take inline stabilization if there's a definite head injury. If needed, establish an airway with a jaw thrust maneuver. Maintain an SpO2 of 94% or above. Use positive pressure ventilation for inadequate breathing. All right, there we go. We have the EMT establishing a spinal stabilization, and they open the airway. They're going to have to use jaw thrust for this airway because they cannot do a head tilt chin lift. All right, head injuries, especially injuries to the face, such as the mandible injury shown here, often cause airway blockage. A lot of suctioning here. You may have to put in an NPA or a king tube to maintain this airway. There's definitely going to be some continued suctioning going on here if he continues to, or she continues to bleed. During your primary, determine the mental status with AVPU. I know we've talked about this already. AVPU stands for alert, verbal, painful, and unresponsive. You will use this in the field. I can guarantee it. Alert means that patient is looking at you. They're talking to you. They may not be talking to you, but they're looking at you, and they're following and they're tracking or whatever. Verbal, they respond to you verbally, and when you ask them questions, they can answer them. Painful, they may not be alert, but you may do a sternum rub or pinch the trapezius muscle, and they may respond to the pain. And then unresponsive is they're not responding to any of the A, V, or P. Okay. All right. The Glasgow Coma scale was something you really need to learn. I will put a copy of it in the classroom, but you really need to learn the Glasgow Coma scale. Anytime you write a patient care report, it's going to ask you about the Glasgow Coma scale. It is the more precise way to determine the mental status. The GCS is a measure of the patient's eye-opening verbal response and motor response to different stimuli, generally reproducible by other healthcare providers. All right, here we go, the Glasgow Coma scale. Eye-opening, spontaneous gets a 4, and you see how it rates. You get eye-opening, verbal response, motor response. So you can get, if you get a perfect score on the Glasgow Coma scale, you get a total of 15 points. Anything less than a 13 is bad. All right. Secondary assessment. Perform a physical exam. Anticipate altered pain response. Check vital signs. Obtain a history if possible. Please always try to obtain a history before leaving the scene. If you can't get one, you can't get one. But always ask if there's someone there that can give you a history if your patient is unresponsive. Inspect and carefully palpate the patient's head. Just because you see an injury right here, you can see it, doesn't mean there aren't other injuries around the head as well. Don't let one little thing catch you and you miss something bigger. All right, when we examine the head, we need to look for deformities like depressions, and we're looking at it right here on the left, soft area or depression. So we're going to feel. We should not be able to push in on the skull. That is not good. Open wound with bleeding and or exposed brain tissue, and then an impaled object. Obviously, that's not a good thing, and we're not removing that object from the brain either. We're going to stabilize it and transport our patient expeditiously. All right, assess pupils for size, equality, and reactivity. Take your little flashlight out, pull their eyes open if they're not open, and we're going to shine the light in there. It's not going to blind them, maybe temporarily for a few seconds, but it will not be permanent. Please assess the pupils. Working in this field, I will tell you that the doctors and nurses would like to know pupillary reactions for any patients that you suspect could be altered or have a head injury. All right, so this patient was riding on a BMX track, doing flips on a bicycle without a helmet or other protective gear. She fell backward and hit her head, causing a cranial injury. Note the blood leaking from her ear. I know some of you are too young to know what BMX are. And you can go look that up and Google what a BMX is, BMX track. Yeah, this pictures are definitely out of date. All right, assess motor and sensory function. We call it PMS, pulse, motor, sensory. Check for that radial pulse, that distal pulse. Check for motor. Can you move your fingers? Can you wiggle your fingers? Can you wiggle your toes? And can you feel me touching you? Secondary assessment, vital signs. Record every 5 minutes. Get a blood pressure. A high systolic blood pressure indicates increasing cranial pressure. Low blood pressure indicates other source of bleeding. If the blood pressure is going down, they're bleeding somewhere and it's leaking out of their body. So you need to look and find out where it is. Pulse, increased rate indicates another source of bleeding because the heart is trying to pump blood where it is losing blood and it's trying to pump it there a lot faster. Decreased rate indicates increasing intracranial pressure or severe hypoxia. Respirations, assess the rate, depth, and pattern. Head injury can alter the rate, depth, and pattern. So if you get some kind of weird rate where they're breathing, it seems normal, then all of a sudden it's sporadic. If it's shallow, if it's really deep, and you haven't assessed the head, you might want to assess the head and find out, make sure nothing's going on. If the following signs are present, consider hyperventilation at a rate of 20 per minute. So what it's saying is if you see any of these things, you want to hyperventilate your patient with a BVM at a rate of 20 times per minute. So if you see unequal pupils, fixed pupils, Cushing's reflex, hemiplegia or hemiparesis. Hemiplegia, that is where we are not feeling any pain, and hemiparesis is, and that means on one side. And hemiparesis is where we don't feel anything. All right. Hemiplegia is paralysis on one side of the body. I got them mixed up. And hemiparesis is muscle weakness or partial paralysis on one side of the body that can affect the arms, legs, and facial muscles. All right. Decrease of 2 or more points in the GCS. So during your secondary, if your patient starts deteriorating, they got a GCS of 13 and now they're at an 11 or a 10, well, you might want to make sure you hyperventilate that patient. Get a history. Ask questions relevant to the head injury. Sometimes an injury to the head days or weeks after an incident in which a patient was knocked unconscious can re-injure the brain. Look for pertinent signs and symptoms. Retrograde amnesia. The patient is unable to remember circumstances leading up to the incident. Anterograde amnesia is the patient is unable to remember circumstances after the incident. Unequal pupils. I don't know how they got this guy to do this. Well, I kind of have an idea, but they did it really good. So that's unequal pupils. This is a non-purposeful response to pain stimuli, including flexion posture. Flexion means they have flexed their arms up to to the inner part of their body, and their feet is turned in as well. And then we have extension where they've extended them out. So you might see these during painful stimuli when you're doing a sternum rub or anything like that. Emergency medical care. Take standard precautions. BSIs. Manual inline spinal stabilization. Maintain the airway, breathing, and oxygenation, which is your primary assessment. Consider controlled hyperventilation, 20 breaths per minute if signs of herniation are present. Monitor the airway, breathing, pulse, and mental status for deterioration. Control bleeding. Do not apply pressure to an open or depressed skull injury because we don't want pressure on that cerebral cortex. Do not stop the flow of blood or fluid from the ear or nose. So if you see bleeding in the ear or nose, don't stick gauze in there. Let it drain, because if there is a brain bleed that's draining out of those orifices, decreasing the pressure. Be prepared for seizures. Continuously monitor your mental status and transport immediately. Reassess every 5 minutes. Pay close attention to the airway and mental status. All right, Matt and Louise recognize the indications of severe traumatic brain injury. Their priorities are continuing to manage the airway, breathing, and oxygenation while immobilizing the spine in preparation for transport. En route, they obtain a complete set of baseline vital signs and perform a complete secondary assessment. At the hospital, the patient is found to have a severe TBI with a subdural hematoma and increased intracranial pressure. He is intubated and there is immediate intervention to relieve the intracranial pressure. The patient is admitted to critical care. Despite rapid and appropriate care by all involved, his prognosis for recovery is poor, as it is for many patients with a devastating head injury. All right, our summary. Brain injuries can be devastating, leading to death or disability. Increasing ICP worsens damage to the brain and can lead to herniation. Treatment is aimed at protecting the spine and managing airway, breathing, oxygenation, and circulation. Consider controlled hyperventilation if signs of herniation are present. And that concludes our lesson for this time, and I will see you next time.